So I'm Katie Reynolds, family physician with St. Luke's Health System, and I've been taking care of patients with eating disorders increasingly over the past 12 years or so. And now these patients comprise about 60% of my practice. And the majority of these patients are adults. Pretty much all of them are over 16. So I work cooperatively with the St. Luke's Adolescent Medicine Clinic, and they see younger patients. So we kind of have a handoff process, so to speak. So that's kind of my basics. I was here a couple weeks ago and we talked about the diagnostic categories and how to identify patients with eating disorders. And today we're going to talk about levels of care. I do hope that people have some specific cases that they want to present, and I certainly don't need to present my cases if there are other ones that are more burning. So, Shannon, go ahead and switch the slide there for me. Okay, so our objectives today are to review the options for higher levels of care. I want you to all understand what those levels look like, and many of you probably have even more familiarity with that than I do. And then secondly, to discuss the clinical characteristics that indicate the need for a higher level of care. Thirdly, to understand the risk factors for refeeding syndrome, and refeeding syndrome is really what drives the appropriate level of care for a lot of patients. And then to discuss challenges with access and patient engagement in terms of what level of care the patient actually ends up in reality. So go ahead and shift. Thanks. Okay, so these are the basic levels of care. So outpatient is, and I'm going to go through these in a little bit more detail one by one, but this is the overview. So outpatient is when the patient comes in to see me in my clinic, and to see all of you in your clinics. Virtual care is a relatively new and expanding option that is kind of an intensive outpatient level. Day treatment includes intensive outpatient, or IOP, and I'm sorry I'll use that abbreviation a lot, but hopefully this will make us all grounded in that. And partial hospitalization, or PHP. And then next level up is residential care, or RTC, inpatient care, and then specialized intensive care. And when I talk about inpatient and intensive care, I'm talking about eating disorder specific care, not what we get in our local hospitals. And so go ahead and advance the slide, Shannon. So outpatient care. So again, we're going to go through these kind of step by step. Outpatient care means that the patient is seeing their medical provider regularly, and regularly can be somewhat flexible. They're seeing their therapist at least once a week, sometimes twice a week, and their dietitian weekly. They also often have psychiatry on board and seeing them regularly. In order to be appropriate for outpatient care, they need to be medically stable, and we're going to talk about that in detail in a little bit. They need to not be actively suicidal. Of course, we don't want somebody just in the office when we can't ensure their safety. All of these slides will have a criterion for weight. That is really a very minor criterion and really misleading. I think more and more the eating disorder community is moving away from weight as a criterion of severity, because if a patient has had substantial weight loss, they may be at a much higher risk than somebody who's at a lower weight but has been stable. So those are really misleading, but it will be on there because it's still on every source you'll go to. In order to be appropriate for outpatient, a patient has to have some decent motivation. They have to want to get into recovery so that they can participate. They need to not have to have supervision with meals because they're not going to get it, obviously. And then with compulsive exercise and purging, they need to be able to modify those behaviors on their own to some degree. They need to have some support at home. That can be family, it can be friends, it can be a lot of different things, but they're going to need people. And they need to be able to live near treatment providers. So they can't get in to see their physician or their therapist on a weekly basis if they live 2 hours away. And they need to be making progress step by step in order to be safely staying an outpatient. Okay, next slide. So I will tell you, I think I have virtual care kind of bouncing back and forth in this. And so on the list, I put it next, but Here I'll explain that in a minute. But intensive outpatient is one of the two types of day treatment. So again, intensive outpatient looks like they're in a facility for 3 to 4 hours a day, 3 to 5 days a week. So it's roughly half day. They're going to have 2 or 3 groups per day. They're going to see the dietitian weekly. They're going to have individual and family therapy weekly. There is typically not medical oversight. And so they will continue to see their primary care doctor. And again, patients need to be medically stable. They need to not be actively suicidal. There's that weight criterion. I would sort of encourage you to take that with a big grain of salt. They need to have some motivation. It doesn't have to be perfect, but they need to be willing to try. Um, they get supervision typically with one meal and one snack, but the rest of the meals are on their own. So they need to be able to try and make some progress there. And same thing with compulsive exercise and purging. They need to be willing to work on that and trying to utilize some tools. They still need support at home, and they still need to be close to the treatment setting because they are going home to sleep at night. Okay, next slide. And PHP is the other type of day treatment. This will be 6 to 8 hours a day, 5 to 6 days a week. So it's full day, but they still sleep at home. They have several groups a day. They have multiple meals and snacks, usually 2 meals, 2 snacks. They're doing weekly individual and family therapy again, weekly dietitian. They're seeing psychiatry consistently, and there's usually medical oversight. They still need to be medically stable, though, because they are going home at night. They can't be actively suicidal. And again, the motivation can be a little bit lower here, but they still need to have some. They can have, and they need to be able to cooperate in program and not be actively, resisting or being, behaviorally acting out. And they can have some intrusive, repetitive thoughts. Typically, these are thoughts about restricting, thoughts about compulsive exercise, body image distress, but it can't be the majority of the time. It can be, a few hours a day adding up. And they need some structure for meals. They need some structure for compulsive exercise, but they're still able to start working on purging. And they need still to have some support at home and be close to treatment because they are going home at night. Next one. Next slide, Shannon. Oh, sorry, there it is. Okay. So residential treatment is 24/7 care. So a patient will be in the facility. They are sleeping there. They're going to be 24/7 supervision. They're going to have highly structured eating disorder specific treatment setting. They'll have 3 to 4 individual sessions in a day, in a week, 1 to 2 family sessions a week, more than 35 groups. So this is much more intensive than PHP. They'll have medical, dietitian, psych, oversight, and daily dietary exposures. Um, so so medically, they need to be able to, they can have some monitoring, but they can't need multiple daily labs. And we'll talk about that when we talk about refeeding syndrome. They can't typically have any kind of tubes in, like a nasogastric tube or a percutaneous feeding tube. Suicidality is typically patients who have some suicidality can go into residential. If it's very high suicidality, they need a higher level than this. Their motivation can be not great. It can be poor, and they're having more intrusive thoughts, but they're still able to cooperate with that environment. They do require supervision for all meals. They need structure for exercise and for purging. And they don't need support people while they're in residential treatment, but of course they'll still need it when they step out, when they step down. And patient doesn't need to live near treatment resources. All of our patients will not live near residential. There are no residential facilities in Idaho. We do have PHP and IOP here in Boise with one Center for Change, but that's the only day treatment, and there's no higher level of care than that. So next slide. And then inpatient hospitalization is typically the kind of the pinnacle for the most part of eating disorder specific care. So patients who are medically unstable go here. Patients who have an active suicidal plan with high lethality or intent. Patients who have had an acute weight decline or food refusal is a really important one. Food or water refusal. They often have very poor motivation. They have persistent and pervasive intrusive thoughts and can be uncooperative with treatment. So comorbidities are also really important, that can drive this level of care. For example, patients who have type 1 diabetes and are withholding their insulin so that their blood sugars will be high and they'll drop weight as a result of that, get in real metabolic trouble quickly. And so they often need inpatient hospitalization sooner. And these patients definitely need supervision for all their meals. They can and sometimes do require enteral feeding, so nasogastric or percutaneous tubes that are feeding, and they need a lot of structure for compulsive exercise and purging. Again, they don't need support from home while they're in care, but they will still need it when they step down. And so our closest inpatient centers, inpatient and residential, would be Utah, California, Oregon, Washington, and Colorado. And I frequently work with all of those providers in all those states to send patients up. And then the if a patient is really, really dangerously ill, there is a specialized intensive care for patients with eating disorders. And the one really in our area is Denver Acute, which is Acute Center for Eating Disorders at Denver. And they take care of patients who are, the sickest of the sick. So they're also a great resource to have. And oftentimes patients are going from our hospital or ICU directly to Denver Acute. Okay, next slide. And then virtual care. Like I say, I don't ever really know where to put this. So really it's mostly at the IOP level. So this is care that patients are getting completely online and from their home. And most of these centers identify as virtual IOP, so that half part day kind of thing. I listed those four that are currently licensed in Idaho. Equip has the most experience with doing this, so they've been around the longest. And they say they can do anything up to residential care. Obviously, if a patient is medically unstable, they can't do that. But so that one, it's hard to fit it into a level. And so these are a really good option for patients who are in rural areas, provided they have consistent and reliable internet access and support at home. Okay, Shannon, go ahead. Okay, so what is this whole medically unstable term that I keep throwing around? So this is a really important determinant of level of care. Basically, when I look at that, I'm looking at vitals, vital signs in the clinic, electrolytes. I'm looking at other conditions, and I mentioned type 1 diabetes. Substance abuse is another really important one that can push somebody up to a higher level of care. Acute food or fluid refusal, that's a quick route to inpatient care, and active suicidality. So those are kind of the main criteria, and a little bit more on the next slide on that. So sorry, this is a yucky slide. But the reason I put it in is this is snipped directly from the APA, the American Psychiatric Association, and their document that is treatment of eating. It's a comprehensive guide to treatment of eating disorders. And on the last page, I give you that link to it. It's free. It's a very large document, and it talks about, what do patients really need as far as their treatment team, and a lot of different criterion or a lot of different guidance for their care. So you can see here, adults and adolescents, there are slightly different parameters as far as what they need for, or what would determine medically unstable. But basically, you're looking at slow heart rate, bradycardia. You're looking at low blood pressure, hypotension. You're looking at blood pressure and pulse changes when they stand. And then lab issues, you're looking at hypoglycemia is a very important one. And when patients die from their eating disorder directly, the two things that are implicated in that are cardiac arrhythmias and hypoglycemia. And so that's one that we need to be very, very concerned about. So when you have a patient who goes in for their labs and they feel fine, but their blood sugar is 43, that's terrifying, because that means they don't get symptoms when they're living at those very low blood sugars frequently. And just because they don't feel it, it's no less dangerous to the brain and to the heart. Other electrolyte issues, potassium, magnesium, phosphate, sodium, those can all be off. The most common and the most concerning ones are potassium, which is typically low in people who are purging or using laxatives. And anything under 2.7 is really frightening and they should be in the hospital. And then phosphate. And phosphate really is one of the key drivers of refeeding syndrome, and we'll talk about that on the next slide. But and then, sorry, it's really tiny on my screen. I shouldn't have put this slide in without giving myself a copy. But EKG was the other thing I wanted to mention on this slide. So I'll frequently hear people talk about QTC prolongation, and it used to be thought to be directly related to eating disorders. It is not. So when we look at EKG changes that are concerning and would indicate a need for higher level of care, things that are directly attributed to the eating disorder would be bradycardia. And then there's some QT interval changes that are kind of difficult to measure and probably not super practical for the average clinician. But QTC prolongation has to do with medications and electrolyte issues. And so it's on there, but that's the current thinking about that. Next slide, Shannon. Okay, so refeeding syndrome. So again, this is one of the things, the risk for refeeding syndrome is really what drives the very highest levels of care. Sorry. So refeeding syndrome happens when blood phosphate level is low. So if a patient comes in and they've got a low phosphate and they start getting nourishment, what happens is that the glucose in their bloodstream increases. Sorry, this is going to be very, very back to organic chemistry kind of stuff. Anyway, so the glucose levels rise. As a result of that, they get an insulin surge. When that happens, it drives all the phosphate into the cells. And if you remember way back to the Krebs cycle, what happens is that if you don't have phosphate, you can't make ATP. And so every single system in the body relies on ATP for energy. So you basically get everything crumbles. It's really scary. So obviously the two most terrifying things there are you get cardiac dysfunction, you can get arrhythmias, you can get congestive heart failure, you get respiratory failure and pulmonary edema, you get peripheral edema. Other organs that are involved, the liver, you can get refeeding hepatitis, which is inflammation. It's actually, well, I'm not going to go into that in detail, but so you can get hepatitis, you can get adrenal short circuiting, so their cortisol levels drop. You can get bone marrow issues, so they can get thrombocytopenic, low white blood cells, low red blood cells. Basically, everything crumbles, multi-organ dysfunction, and death if it's not addressed appropriately. And so that's why it's so important that these patients are in a center where somebody really understands this and can prevent it. And so the basic outline of that is that patients need a lot of phosphate. Even a patient who comes in with a relatively normal looking serum phosphate, if they've been severely undernourished for a long period of time, they often need phosphate 4 times a day, and it's being monitored at least twice a day with labs. And then that the rate of renourishment is really important and starts. We used to start much lower, like at 800 calories, but now it usually starts at 1800 calories, and then with very intensive monitoring and gradual increases as the patient tolerates. Okay, next slide. So how do we know if somebody's at risk for refeeding syndrome? So I don't ever love these lists that say one of these or 2 of these, but that's what we got. So if a patient has any one of the top 3 bullet points, they're really at high risk for refeeding. So there's that BMI in there, which, as you know, I'm very skeptical of. But truly, those very low BMIs, patients are at much higher risk. But also very important if they've had a significant weight loss in the last 6 months. So a patient could be at a normal looking weight, but if they've really dropped in the last 6 months, they may be at risk for refeeding syndrome. If they've had little or no nutritional intake for greater than 10 days, and then they have abnormal electrolytes at admission. The other scenario is if they have 2 of the bullet points below. So kind of a slightly higher BMI than that, or weight loss that's not as severe in the last 6 months, or little or no nutritional intake for just 5 days. So it doesn't take very long to really get in trouble if they have acute food refusal. Um, and a patient who's using alcohol or drugs, that definitely increases the risk for refeeding syndrome. And I mentioned abuse of insulin is a factor. Also, we're seeing increasingly abuse of GLP-1s. I recently heard about a patient who was getting 4 different GLP-1s from 4 different providers. And so something like that, those patients are really at higher risk for refeeding syndrome. Diuretics, antacids, frequent purging, all those things make the risk higher. Okay, next slide. So we know what level of care a patient should be in. They often don't end up in that level of care, and these are the reasons why. I Cost of care is really crushing. And so if it's not well covered by insurance, I have yet to meet a patient who's independently wealthy enough to pay for it out of pocket. So that's a real problem. When patients are in residential care, they're typically looking at a 12-week stay of tens of thousands of dollars. So again, very high costs of care. Um, patients Patients who are insured have the insurance networks are typically quite limited. Many insurance companies will contract with just 1 or 2 treatment providers. And so if a patient has been to the same facility 4 times, it's probably not appropriate for them to be there again. They probably need a different approach and a different way of treating their illness. But sometimes that can be very challenging because of insurance networks. Prior authorization is frequently needed, and gap referrals, things like that. These processes, especially the gap referrals, take weeks. And so you can imagine if you've got a patient in front of you who is sort of hovering on the brink of medical instability, what we end up doing oftentimes is hospitalizing them at our local hospitals, and then and continuing that process of prior authorization. I've seen patients who are hospitalized from the local hospital, discharged, hospitalized again, discharged, and finally get to a higher level of care. So it can take a very long and scary period of time. And one of the real problems with that we see is that when a patient's been in the hospital, especially if they're sort of questioning what they really need to be doing with their treatment, they'll say, well, I already got treatment for this. But of course, what we're doing in our medical hospital is very different than what an eating disorder specific facility would do as far as treating a lot of those underlying issues. And so it can really be damaging for some patients to sort of get that partial treatment. Um, Patient and parent willingness is a big hurdle. So I don't know if any of you have heard of the book Sick Enough. It's a book written by Jennifer Gaudiani, who's really one of the forefront of outpatient eating disorder care. And the reason she called it that is that every single patient who has an eating disorder will say, I'm not really that sick. Most of them will say, I feel fine. And that's part of the illness. Just like people who have depression will say that they feel like they're a burden to family and friends, people who have eating disorders will say, I'm fine. I'm not really that sick. And so that's a real issue with trying to get them to higher levels of care. Parents oftentimes will be reluctant either because of stigma or often because they just don't recognize the severity and the risk for their kiddos. Um, so those have to be overcome before you can do anything, and that doesn't happen in one day frequently. Distance, I mentioned, is an issue and very much an issue in our area. I wish we had more options. There are many patients who, even if they can get to residential care, they're really reluctant to be that far away from home, from their work, from their kids, from their school, from their family. And I mentioned the role for local hospitalization already, so we'll skip that. Next slide, Jen. Okay. So I'm gonna Shannon, do we have any cases in the chat that anybody has mentioned?
We don't have cases yet, but we do have questions. So maybe we want to pause and do Q&A, and then we can move forward from there if we've got time. So we had the first question that we had was somebody asked a little while ago, I can't find it anymore, but is there a reason why the criteria are focused more on weight loss instead of weight gain?
Um, so when we're looking at, so we're talking about prior to treatment. So when a patient first presents to my office, what I'm looking at is their weight trajectory. And so I'll give you a pediatric and then an adult example. So if I see a 15-year-old or a 16-year-old who they've been in the 50th percentile all along, and all of a sudden they drop off, that's very concerning. And so, really, what's happened in the last 6 to 12 months tells me how metabolically at risk they are. Same thing with an adult. Unfortunately, some of my adults who have eating disorders have never been at what I would say a biologically appropriate weight. And what I mean by that is that a biologically appropriate weight means that you're stable without dieting, without using any compensatory behaviors like purging or compulsive exercise. And so that's a sustainable weight in a healthy way. So if we know what that weight is, then we're trying to figure out, how much they've dropped from that, and that again really drives how much they are at metabolic risk. This is really hard in the era of GLP-1 inhibitors or GLP-1 agonists because patients have lost 100 pounds and they might be at risk for refeeding. They might be really sick, or they might not. It really depends on that. So many other things. It really depends on their behaviors and their biologic set point and things like that. Um, so I hope I answered that question.
Yeah, Catherine did. Sorry, Catherine, I knew I saw that question earlier. I was trying to find it, so I guess that answers my question. You deleted it. She said, "Thank you. I deleted that question because I was struggling to figure out how to word it, but Anna got it. I know that folks with higher BMIs often get overlooked for assessment and treatment of eating disorders."
Yes, I 100% agree. So that's why I kind of throw out these BMI numbers, but I do not think that is the most important thing. They have been, when I first started doing this work 12 years ago, that was really the primary thing we were looking at was if a patient's at X BMI or they've lost this much on their growth chart, that is less and less considered to be important. So and with that understanding that patients who are at a higher body mass index but have lost weight or are weight suppression is the term that we use, that they are equally metabolic risk. So you can see a patient who looks from the surface like they're still, in a larger body, but they may be very dangerously depleted and at risk for refeeding syndrome. And so even Denver Acute that does the, like I say, the sickest of the sick, they have dropped BMI as one of their, sort of mandatory factors for who they will consider because they also recognize this.
Thank you. Okay, a couple questions about binge eating. Anna said, "How are these decreases in lab values impacted if a patient is binge eating?"
It can be all over the place. I think really what I see is that it is the constellation of the behaviors that determine what we see on labs and physical exam. And so if a patient is binging and not purging or using some kind of compensatory behavior, we typically don't see much in the way of lab changes. Now that, yeah, I'm gonna stick to that. um, but if they're doing any kind of laxatives or diuretics or abusing caffeine or nicotine or any of those things, then you can start to see electrolyte changes. I think the community as a whole really has struggled a little bit to determine what is the appropriate level of care for binge eating for patients with binge eating disorder because um, we're seeing we've just kind of scratched the tip of the iceberg with those patients. There are many out there that have not come into care, and when they do, it's difficult, as you can imagine, for a patient with binge eating disorder to be on the same unit as a patient with with restricting anorexia nervosa that does not binge and purge. It's just of many of the things that they do as far as body image and underlying mental health issues are identical, but it's challenging for patients to be in that same milieu. So virtual care has been really helpful for that. And there are more and more facilities around the country that are designed specifically for patients with binge eating. But that whole idea of sick enough is really challenging for patients with binge eating disorder. There's a ton of shame that goes around that because it's not considered virtuous in our society like restricting is, which is crazy. Um, and so they're both, extremely damaging to your health, but somehow we sort of reinforce people for eating 600 calories a day. And so they're really reluctant to get into care and even to come to divulge any of that to their primary care provider or their therapist.
And next question, I think you've kind of already answered this, but what's your view on binge eating disorder at a high weight requiring treatment such as RTC?
Yeah, I mean, they definitely do. They definitely do. And I think it's a matter of A, convincing the patient, B, convincing insurance, and then finding a facility that is appropriate for them. Yeah. And like I say, I think virtual care is a really helpful option for these patients because then they really are paired with people who are struggling with the same things they're struggling with.
Excellent. Thank you. Okay, those are our questions in the chat. Any questions from folks that you would like to ask or questions from our panelists for Catherine? And then I'll just put it out there too. If anybody, I know last week Tara had a case. Tara, do you have any updates on your case at all after our last session?
Hi. Can you hear me?
Hi.
No? Can you hear me? Yeah, yeah.
Yes.
So not a whole lot. I've been a little bit in touch with their counselor, and I think honestly that kind of goes back to like it's a really obvious thing, but I think this feeling of like how hard some of these cases, and I know we've worked on some cases that are just in real life, like there's the ideal of how it should work, and then the in real life primary care and like getting a hold of the patient care coordination, like how that all works. So I've talked a little bit to their counselor. Now we're playing phone tag to get on a call so we can at least all be on the same page because of some of the what I've experienced a little bit goes along with some like splitting or people telling one provider one thing and another provider another thing and not wanting to kind of admit how hard those things are. So I'm working through that with that particular patient. But I think I brought it up at our provider meeting today at our clinic because I think that it was only a matter of, I think all of us have had that feeling about the GLPs and how the GLP-1s are involved in, because for those of you who weren't on, the case last week did involve some of the GLP medications and how the patient was obtaining those. And I think we're just all in this little bit of the Wild West of, tools that are really good for certain people. And I'm so grateful we have them, but then trying to figure out how even some of the pathology is going to shake out. So it's just a work in progress. And everyone was kind of like, you see all of our heads kind of trying to spin, figuring out how to not do harm and do good and all the same things.
Tara, I think you make some really excellent points. I think one of the things that I'm seeing from my, I guess, relatively unique perspective in terms of GLP-1s is that what patients are really seeing is that patients who are in larger bodies have always been told, and often by medical providers, that they are wrong, bad, lazy, and just should be ashamed, even if their behaviors are really exemplary. These patients are eating way better than I eat and exercising way more than I do, and they're going to be told by multiple people that they need to eat better and exercise more, or and eat less, eating 600 calories a day. And the other part of it, so it's the GLP-1s are another layer to that. Like you should fix yourself, right? And I think that can be a really, really pernicious message to patients, especially when, well, for many reasons, but including the fact that access to those is clearly not equal. The cost is huge. The other part of it that's challenging is that it seems like a quick fix, and we love quick fixes in our society. And so, a patient who's really struggling with, I've seen a lot of patients who are struggling with binging, either in the context of anorexia nervosa, binge purge subtype, or bulimia, where it feels out of control. And so taking a GLP-1 will take that feeling away, but it doesn't address any of the underlying things, and it can be extremely metabolically risky for those patients. So, yeah. And the other point that you made was about coordination, and I'm so glad you made that. So it's something I meant to talk about. Really, in treating these patients, one of the most important things is to really have an open conversation between the medical provider, the psychiatric provider, the dietitian, and the therapist. And I spend a lot of time talking with all those folks and really trying to say, well, here's what I'm seeing. What are you seeing? Here's what the patient told me. Oh, I didn't hear that. So that is really important, because a lot of this rests on a lot of our assessment rests on what is their function, how much is this messing up their life, and what's the severity of their behaviors. So that is, and I think frequently that patients with eating disorders, there's a lot of similarity between eating disorders and substance abuse. And so part of the disorder is trying to conceal or even lie about behaviors, not because they're bad people, but because it's part of the illness. And so it is really important to get an accurate picture, and coordination of care is collaboration is really the key part of that. And I know, Tara, we've worked on some patients where ethics are really so challenging. And this frequently comes in with adult patients where, I have patients who've had eating disorders for 30 years, and they've been in and out and in and out and in and out of treatment, and they don't want to do it anymore. And so I can be looking at them in my clinic and say, well, you're really scary metabolically, and I know you're not doing well, but also you have decision making capacity, you are competent to make these choices. And so then what do I do? So thank you.
Thanks for that, Katie, and thanks for the follow-up, Tara. Dr. Bradbury, I see that you have a question. Do you want to ask your question?
Yeah. So I have actually two questions. They're about the same patient. Maybe you could give me some advice on this. So this is a patient who we suspected might be at some refeeding risk, not underweight. So again, not using the BMI criteria at all, but had a substantial weight loss over the last 6 months, and more what she reported than we actually measured. Not as bad a weight loss here, like maybe about a pound a week here, but she had reported a much bigger weight loss, kind of intentional. And so we were kind of concerned with refeeding syndrome. She'd been in and out of facilities before and didn't really meet criteria to be hospitalized. So we decided to check labs. And now she's being more compliant with what the dietitian is recommending, or at least she's claiming she's being more compliant. And a couple of sets of labs have been okay. If you had those kind of concerns, how long do you keep bothering to check labs on somebody like that? If now they seem to be more compliant and maybe that risk phase of the refeeding's gone, how long would you keep checking labs?
That's a really tough question. I think there are so many details in there that would influence that. I think one of the biggest issues is how low was that person's caloric intake prior to becoming more compliant, and then how quickly did it shift? We know that the worst risk is in the first 7 to 10 days. Sort of throw numbers out there, but it really depends on, again, what that trajectory of nourishment looks like. In patients who are at highest risk, they really need to be getting labs done twice a day, which we can't do in an outpatient setting and shouldn't be trying. But if she was at 600 calories a day and now she's at 1,200, that could definitely increase the risk. And if she's jumping it up by more than 300 calories every few days, that also increases the risk for refeeding. I don't know. Does that answer your question? I'm not sure.
Yeah, it does.
Concrete.
Right. Look at the trajectory and all that makes a lot of sense.
Yeah.
The other question with the same patient is, although she claims to be working with the dietitian and all, she really has zero insight into the situation. Unfortunately, is reinforced as often happens. She was sent to the emergency room by one doctor, and of course at the ER, everything they did came back perfectly normal. So and not only that, she's got friends telling her, hey, and her BMI is up in the it's actually in the overweight range, and her friends are saying, "Hey, this is great. You're losing all this weight." So she has zero insight, doesn't meet criteria for hospitalization. How do you break through that, or do you just sort of limp along with those people, hoping one day they'll change? Is there a way to break through that barrier? There's a huge piece of personality disorder here too that's getting in the way, right? So
Yeah, I feel your pain. I feel like I spend most of my days limping through that process with each patient. So I think the way I look at it is that number one, I keep in my mind that all patients think that they are not sick, right? And I think that's important. And I often share that with patients. I'll say, listen, this is part of the disease. The other thing is that I really try to think of it from a stages of change model. And so when a patient comes to me, they're typically pre-contemplative, and we know, and please, all of the behavioral health folks on the line, please correct me if I'm saying this wrong, but really what I'm trying to do there is point out to them in the ways that their body is not working well, and the ways that this is compromising their function and their life, so that we can hopefully move that patient into a contemplative stage. So I think that's really what you can do for adults. So I always say, my job is to, you know, try to assess where you are metabolically, try to determine, current medical risks and future risks, and then help you understand, where you are in terms of the disease and how you can get to recovery and get your life back. So
I appreciate that. I mean, I think that's very reassuring and goes along with my impressions. I mean, try not to break the relationship with the patient in the hopes that maybe there'll be some progress in the future. I guess the question I was asking is, my impression is to look straight in the eye of the patient and say, "You're really this terribly sick person." That doesn't go anywhere, right? I mean, they completely shut that off immediately.
yeah. Yeah. So I try to, I have some starvation checklists that I will have patients say, hey, check these symptoms, and just and then I'll say, well, what that actually was a starvation checklist, and you've just said yes to 15 of those things, right? And so sometimes, I don't know, sometimes that's a little bit helpful. I think it's really more about trying to understand how the patient views it and work with them to maybe open a window in terms of how else they might see it or what you're seeing. Um,
And
yeah,
helping them come to their own conclusion.
very slow to build in most of these patients.
Yeah, thank you.
Thanks, Dr. Bradbury. Jeremy, I saw that you had a question, and also would be great to Catherine if you could share the starvation checklist with us at some point.
Yeah, thank you. Dr. Bradbury, on mute. No, Dr. Bradbury kind of stole my question about, involuntary, those like ego dystonic people who don't share goals with us in treatment. And I guess I'll piggyback a little bit. At what point do you call a person gravely disabled and try to initiate some kind of like a outpatient hold or something when they're struggling with an eating disorder?
Um, Great question. That is an extremely steep hill to climb. So I have several patients in my practice who are adults, obviously, who basically are refusing any kind of higher level of care despite being medically pretty sketchy. And I've gone through this process frequently with, including one patient recently where I consulted with the ethics team, the palliative care team, psychiatry, inpatient and outpatient. And patients in these situations are rarely, that patients almost always have decisional capacity. And so I think most of we're not, competency is not really the term we use, that's a legal term, but decisional capacity means that a patient they understand the severity of their situation, they understand the risks of the pros and cons of different types of treatments, including no treatment, and they're able to consistently tell you what they want. Many of these patients, particularly who've been in and out of treatment, will say, I'm not doing it again, it doesn't work. And if they're not actively suicidal, again, that is such an interesting line, right? Because they're basically saying, I know I'm going to get worse and I know this disease is going to kill me, but they're not actively suicidal. And that is, a lot of the art of medicine. But I look at it frequently as similar to patients who have cancer and have tried 3 different chemotherapies and say, I'm not doing the next one. That's different than being actively suicidal, right? And it's the same thing with patients who've been in and out of care and have had their disorder for 30 years. So That is very challenging. I will tell you, just as an anecdote, I had the patient that I ended up consulting ethics and palliative care and all of this. She started going down a palliative care route, which was really scary to me. That's not something I was very comfortable with. And when she started going down that route, she decided she wanted to get care and see if she could really get a life for herself. And so she's at Denver Acute right now. So I think sometimes really meeting the patient where they are, even if it's scary, can allow the possibility for change.
Thanks so much, Katie. Thanks for the question, Jeremy. We have a few questions in the chat still, so I'm going to read those for you, and then we still have 9 minutes left. So other questions too, feel free to put them in. This is great conversation today. So from Anna, are there any tips or tricks for talking with patients or students we get through the health office with disordered eating concerns we may have, or talking to their parents?
Yes. So I think when you have a patient in front of you, you're just wondering, does this patient have an eating disorder, and how much do I need to worry? Really, the question is, what are their behaviors? And so I never start with, here's your BMI or here's your growth chart, ever, ever, ever in any patient. I always start with, hey, what's nutrition like for you? How, do you have things you avoid? Do you ever try to avoid certain foods, or skip meals? I kind of start with general questions like that. So I would encourage, when you're seeing somebody who doesn't have a diagnosed eating disorder, start there, and then gradually dig into more about their behaviors and how it's affecting their lives. Did that answer the question? I'm not sure it did.
And then any advice for talking with parents? I think this one comes from somebody who works in a school setting. So just for that context.
Yep. I think, again, trying to educate parents that it's not just their BMI or their body shape, but it's really the behaviors that determine how sick they are. There are, I'll put it in I'll send it to Shannon, but there's a wonderful website that's called Feasted. And I'm sorry, I always forget what it stands for. It's kind of a weird name, but it's basically a resource for families and caregivers and support people of patients with eating disorders. And they have wonderful resources about, like, how do I even talk to my family member, or how do I support them in a way that's truly supportive? And so I think that's a resource I often send parents to. Many of the programs will have, there's also NCEED, which is the National Center for Excellence in Eating Disorders. They have some patient-centered information. So I try to just let parents know, nobody knows about this. Many medical providers don't know about this. Many people who are in clinical medicine don't know about this. And so, of course, you're not familiar with it, and you don't know, what you're dealing with. And so let's work on, giving you more resources.
That's great. Thank you. I did put the Feast Ed in the chat there. And then I'll also add that to our overview page as well.
Perfect.
And then next question from Gretchen. Apologies if I missed this, but do you have recommendations for individuals with Medicaid for ED referrals across levels of care? I always struggle to find specialized ED treatments for this payer.
Yeah. I had on my notes to talk about that Medicare and Medicaid are extremely challenging. So I know that the adolescent medicine folks have had some success with patients under 18, getting those Medicaid patients to higher levels of care. As soon as they turn 18, it's almost impossible in my experience. And so it is extremely challenging. It takes a single case agreement, which, like I mentioned, takes weeks with any insurer, but with Medicaid and for adults, it takes about 6 months if you're going to get anything at all. So it is extremely challenging. And Medicare basically does not cover higher levels of care. They will cover 2 weeks of inpatient care and then no step down care. And so, so I share your pain. It's something that really needs to change. There were some conversations about changing that for Medicare patients, but I think those conversations are dead right now. So I guess the way I approach that, and to maybe not leave it in such a hopeless way, is to really maximize what we're doing with the outpatient team, and also to utilize local inpatient medical units that are not eating disorder specific to kind of temporize and get the patient out of metabolic danger as we're trying to do outpatient work.
Thank you, Katie.
Mm.
Any other questions? We have a couple minutes left. Are there any last questions for Katie today? Okay, little wait time. All right. Katie, I don't know if there's one of these cases. We've got about 5 minutes left. If there's one case of the ones on here that you want to go through in just a minute or two, or if there's any other thoughts, I don't know if you'd like to just hit on anything else.
Sure. I think I could whiz through all three of them really fast.
Okay.
So the first case, if you come to it, is a patient who 15-year-old with food and water refusal. And that's all it says on the slide because that's all that matters. That patient needs inpatient care. So that's a quick one. Next. And then this is a patient who's, my age, has had her eating disorder for a long time, purging 6 times a day. Phosphate is 0.8, which is terrifying. So again, inpatient care. This is more complicated. 19-year-old, multiple previous admissions. So the patient really doesn't want to do anything. Vitals are okay. Labs are okay. Depression is getting worse, but she's not actively suicidal. Weight is stable. Intake is not great. So 30 to 40%, I'm guessing, of her caloric needs, and is dropping off over time. Not purging, has some decent support. So if we kind of click through the checklist in our minds, medically stable. She's not actively suicidal. And then we start looking at, well, how much supervision does she need? Well, she's not doing great with her 1 to 2 meals a day, so she needs some. So outpatient care is not great. And also things are getting worse, so outpatient care is not great. So this is a patient that I'd be thinking about IOP, PHP, or virtual care. And this patient actually did admit to one of the virtual programs, and just in the last 10 days. So more to come. But I have had really good outcomes, and the data shows good outcomes with virtual programs.
Awesome. Thank you so much. That's great.
Thanks.
I just wanted to make sure we went through those because I know we didn't get to those last time. So thank you so much, Katie. This has been fantastic.
Thank you so much.
This has been such a highly requested topic for a long time. So I'm really glad that we were able to have you come for 2 sessions and to talk about this. I did just want to put a plug in that it seems like these topics have been really, really popular with a lot of you guys. Next fall, Echo is going to be putting on a women's nutrition series. So again, we're pretty far out, 9 months out, but just keep that on your radar that we will be having something more along these lines. So keep that in your back pocket. We are going to be back in 2 weeks for our last session of 2025. We will have Dr. Steven Sacklett, who is a PharmD and a clinical professor at University of Texas at Austin. He will be presenting on new psychiatric medications to just wrap up the year before we get into everything for next year. So thanks again, everyone. Thanks again, Katie. This has been fantastic. And we will get all those resources uploaded to our website so that you guys can access them. So thanks, everyone. Have a good day.